We know that if some dental conditions are left untreated, they become so severe that they actually become a medical emergency, and therefore admission into the hospital is necessary. So the objective of this report was to analyze key trends in those inpatient hospitalizations for non-traumatic dental conditions. A lot of times, those very same patients don't receive the dental care they need. They end up back in the emergency department. And then from there, now the situation is so severe that inpatient hospitalization is required. And I think that's one of our main jobs as public health professionals and researchers, is that we really need to be getting these stories out into the hands of the public.
Hey everyone, welcome back to a bonus episode of A Tale of Two Hygienists podcast. My name is Andrew.
And my name is Michelle.
So for those new to the podcast, each week Michelle and I bring on an amazing guest from the dental world who fills our nerd brains with new insight or affirms our clinical abilities.
And we are so grateful for the time and effort these guests put into making us better. We also wanted to acknowledge that this episode is powered by Crest+Oral B, and this episode wouldn't be possible without them.
And we know you guys are going to really enjoy this episode.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
So we are really excited to have a return guest. I love when we have return guests. You heard Josefine before. This is brought to you by Crest, and she is back again to deliver a very interesting article to us, some research that I'm assuming that you participated in. So welcome back. How are you?
I'm doing well, guys. Thanks for having me back.
Of course.
Your last episode was so informative and it was so well received by our audience. Like, we just couldn't wait to get you back on again.
Oh, thank you. I had a lot of fun recording that episode.
So did you do this research? Tell us what you're here to talk about today.
This research was actually conducted from the Texas Health Institute, which is where I work. They are our public health institutes all across the country. This is the one that is located in Texas. I collaborated with my team, Ankit Singhavi, Gaurav Patel, and myself. I'm the director of oral health at the Texas Health Institute to conduct this 10-year analysis on inpatient hospitalization trends for non-traumatic dental conditions in Texas. Now, I know that sounds really wordy, but really all it is we looked at some numbers over a 10-year period. Now, before we start, I just want to clarify a couple of things. So there are emergency department rooms in hospitals, and then there are patients who are actually inpatient patients at hospitals. So this study is really just looking at those patients that were admitted into a hospital for non-traumatic dental conditions in Texas. So a non-traumatic dental condition is really anything in the mouth that wasn't caused by a traumatic event, say intimate partner violence or an automobile accident or anything like that. In most cases, these non-traumatic dental conditions, and we call them NTDCs, are things that can generally be treated in a dental office. So this study looked at patients over a 10-year period that were admitted into the hospital for dental conditions that were non-traumatic.
Gotcha.
So does this include like emergency room stays as well, or visits, I should say?
So what we looked at is we looked at only those patients that were admitted into the hospital. So a lot of times when somebody goes into a hospital or into an emergency department, a lot of times they get palliative treatment for a dental issue and then they get sent home. Palliative treatment is usually something like an antibiotic or some type of pain medication. And then they get sent home with those prescriptions and a bill. But what's important to remember about emergency department patients is that the dental condition is not treated at all. They simply go in, get palliative treatment to relieve the pain and the swelling, and then they get sent home. This particular study only looked at those patients who presented either through the emergency department or sometimes through a physician's office. They got to the hospital and the physician said, this condition is so severe and so life-threatening that we are now going to remove you from the emergency department and place you in an inpatient setting. Or the patient showed up at a physician's office and the physician said, we are immediately transferring you to the hospital as an inpatient. So this particular study does not look at emergency department visits. That's a different that's a different population. We have actually done studies on emergency department visits as well. But for this particular study, we're actually talking about those patients that actually showed up and their dental condition was so severe that the medical professional felt it necessary to immediately admit them into the hospital.
And this might not be part of the study, but just as my brain's trying to work here, how many of these conditions, though, if they would have showed up at the dental office, would we have said, hey, go to the hospital, you need to be treated? Or is this within our scope of practice that we could have just taken care of the problem right then and there?
So the problem is that these patients did not show up at the dental office. Had the patients shown up at the dental office, then that would have been a different story. That would have been a different story to tell. In some cases, the infection was already too severe. They would have ended up in an inpatient setting. But it's really hard to tell. We didn't specifically study those things. So what we did study were those patients who were referred to the hospital as inpatient admissions from their primary care physician in some cases, and in some cases straight from the emergency department.
So are we talking infections like osteomyelitis, like that severe, or?
Okay, so a little introduction on the purpose of this analysis. We know that if some dental conditions are left untreated, they become so severe that they actually become a medical emergency, and therefore admission into the hospital is necessary. So the objective of this report was to analyze key trends in those inpatient hospitalizations for non-traumatic dental conditions. We analyzed the utilization rates, the primary diagnoses, the total charges, and demographic characteristics. So what we mean by utilization rates is who was using the hospital for dental treatment. Primary diagnoses, why were they going into the hospital? Total charges, not to be confused with costs, and the demographic characteristics such as age, gender, race, and ethnicity. So the current situation right now for folks that have dental conditions and no access to care is a lot of times they'll end up in the emergency department. And the emergency department will then say this dental condition requires antibiotics or pain relievers. So the patient gets that and they get sent home. A lot of times those very same patients don't receive the dental care they need. They end up back in the emergency department. And then from there, now the situation is so severe that inpatient hospitalization is required. And again, those are the folks that we're talking about, are those that are in the hospital. So the World Health Organization, we know they tell us that dental or oral disease is one of the most common diseases globally. So this particular study looked at Texas residents, but this is not a problem that is by any means unique to Texas. But in Texas, actually 54% of adults have periodontal disease. That's over half of the population.
It's actually lower than I would have guessed.
Yeah.
Not just for Texas, but just for as population goes.
Right. Yeah, I agree. And 66, so almost over two thirds of children have experienced tooth decay. So those are sort of the kind of the numbers where we are at in Texas. 13% of Texans over the age of 65 have no teeth at all. So we know that directly affects their ability to manage other chronic diseases. So it's a pretty serious problem. Okay, so where did we get this information? Where did we get these numbers from? We got them from the Texas Hospital Inpatient Discharge Public Use Data Files from the Texas Health Care Information Council. So Essentially, the hospitals are required to sort of produce quarterly reports. And that's where we got this information from. We accessed those reports and then we put the numbers together. And we looked at age, gender, race, ethnicity, the primary diagnosis, the payer type. The payer type is who is paying for the services. So we looked at all of those different variables. The patients that we decided to analyze, we used a list from the Association of State and Territorial Dental Directors. You might have heard it called ASTDD. So they have a list of codes which they consider non-traumatic dental conditions. And so we used that list that they recommend of codes, and we sort of picked the patients out of this huge data set that had any of these codes. And that's how we looked at the data. So that's how we knew folks were showing up with non-traumatic dental conditions. So that is pretty standard for research, is to use these codes from ASTDD. So some of the things that we looked at were particularly payer types, because that's important. We looked at charity cases, Medicaid, Medicare, private insurance, and other payers. And charity cases is kind of a difficult one to really define because it means something different at each hospital. But essentially, a charity case was either what it sounds like, care given for free, but it could also include bad debt, folks who were not able to pay for their treatment or only paid a portion of their treatment, or things like this. So it's just difficult to say, but that charity type is all lumped into one.
Why is it important to look at that as a data set?
Because currently in Texas, there are no Medicaid benefits for older adults for dental care. And so we wanted to look at how many folks were going in that had Medicaid or Medicare as a medical service or coverage. So that's why that was important. And what was really interesting is that over the 10-year period, there were 47,926 admissions. That's almost 48,000 admissions. And the total charges that were incurred were over $1.7 billion.
With a B, billion with a B.
Wow.
That's billion with the B. The average charge over the 10-year period, the average charge was $37,000, which is a lot. The average Texan makes about $47,000 a year. So what was really interesting about this is that 58% were working age adults between the ages of 20 and 64. So not only was there a charge of $37,000, the cost to the family or the cost to the patient was much greater than that, because we're talking about folks who would then have to miss work or may have to hire somebody to help take care of kids. So the cost to the families is a little more difficult to measure. What we also found was that the highest in-paid admission rates, when we looked at individual counties, the highest admission rates were in rural counties. So those folks in rural counties absolutely had a higher need. When we looked at race and ethnicity, though, we found that 52% of all admissions over the 10-year period were for patients with non-Hispanic, white, racial, and ethnic backgrounds. So a lot of times we think public health interventions really only help minority populations or maybe poor children. But in this case, we're talking about white adults. 52% of the admissions were non-Hispanic whites, is what we found. So this really tells us that there is a systemic impact, that the problem is not just localized to one particular population. This is truly a systemic issue. All populations are in need. So that's one of the interesting things that we found. So when we talk about, I think that Michelle asked, what types of things were folks going into the hospital for? So what we found is that for when we divided them up into payers, is how we did the analysis. So cellulitis of the face secondary to NTDCs were really the most common. So cellulitis, which is that infection at a deeper level. But interestingly enough, Medicare patients had cellulitis, which is the inflammation of a salivary gland. That was the most common diagnosis at 22%. So when we look at some of these conditions, the majority of the conditions that folks were going into an inpatient setting for could have been treated at a dental office for a lot less than $37,000.
That's absolutely what's kind of been in the back of my head every time that patient's like, why is this so expensive? And you're like, well, it's a surgery on a tooth or, amputation of a body part. Like it could be way worse.
And that's just the dental condition. Those are just the charges from the hospital. When we really think of the costs that are incurred, the loss of work, how does that impact a person's career? Or a child missing school? How does that affect their overall ability to succeed? So those are things that are difficult to really measure the costs there. But what was also interesting, though, is a lot of times when we think of state-sponsored dental plans, so state-sponsored meaning like Medicare or Medicaid, and expanding those benefits, a lot of times we think, well, that's just going to be very expensive. Whereas our government, where our taxpayers going to get the money to pay for this. But what we found was that public insurances or those state-sponsored insurances were already covering about 2 out of 5 of those admissions over that 10-year period because now it's a medical necessity in order for this to be treated. And Medicaid covered 16.2% and Medicare covered about 21% of those inpatient admissions. So that's almost half of those inpatient admissions. So that's also an interesting thing to keep in mind.
We say it all the time, like it's not, the mouth doesn't stop at the throat and just stay in its little bubble. This is such a great example.
And medicine doesn't stop at the neck and not go up. It includes mental, dental, it's all inclusive. It's so important. Yes. So those are some of the interesting things that we found. We also looked at the cost per admission, which we mentioned earlier was $37,000. But what we also found was that it increased about 61%. So it started off in 2007 at $28,000. And over that 10-year period, it rose to $46,000. So that is a 61% increase over that 10-year period. So what started off as $28,000 is now in 2016, $46,000.
That's a huge increase. So, is everything increasing in the hospital at that rate? Or is that just these procedures or these conditions?
So we didn't analyze it in comparison to other things, but we do know that in general, medical care is increasing in cost in the United States. So this is pretty consistent with the other findings. But really, what is so important about this type of information is that we really are able to translate the information to our patients. So I know that we've talked a lot about numbers and terminology, but now let's talk about how you can take this to your patients and how you can begin a narrative with friends or family and even your politicians in your local communities. So one of the things that we know is that the need for dental care does not affect just one particular population. It's systemic, as we saw with the data of the majority of ethnic groups was non-Hispanic whites. So it does not just target one population. This is really a systemic issue, and it covers it affects all populations. Another thing that's important is that when we think of the cost to families based on the charges that we just talked about, we would want to consider, where would we rather use our monies? Would we rather use them to treat a patient in a hospital setting? Or as taxpayers, would we rather use our money to prevent decay? Now, in this 10-year period, we also identified 196 Texans that actually lost their lives due to non-traumatic dental conditions. So that's 196 individuals who died because of dental issues.
Wow.
That's a lot. Now, let's think about that. Those are individuals that made it to the hospital and are now receiving medical treatment, yet still lost their lives. That's 196 Texans.
That's fascinating. I mean, I wonder if you could take kind of like those people and pull them out and actually see, because the news doesn't talk about this stuff. Like people, no one's going to die from a toothache, but actually, yeah. And talk about that a little bit more. I think that would be amazing.
Yeah, Michelle. So that's very true. A lot of times we think, oh, they're just teeth. We can do without them. But actually, it can cause even death. And we do intend to further study the 196 individuals to really figure out what was their primary diagnosis, what was their ultimate cause of death, what were the payers, what were the charges associated with those 196 deaths. And that's maybe another episode.
It would also, I mean, I feel like this is such a great study that you could then just pilot off these other ones, because it would be also interesting to know like how many of these people were diagnosed in a dental office and didn't follow through, or never even made it to a dental office, or were watching problems, like all the things that we talk about. Like even if you just siloed it into the people who lost their life and actually really kind of took it back to the original, like had they never seen a dentist? And if there are in rural areas, how many dentists were available to you could make some really good articles from this information you guys did.
Right. And I think that's one of our main jobs as public health professionals and researchers, is that we really need to be getting these stories out into the hands of the public. And sometimes when we're looking at these sorts of studies and we're looking at statistics and the epidemiology behind things, we tend to not think about the stories that are behind all of these numbers. But behind all of these numbers, there are stories. Why haven't folks been able to get to a dentist? Was it because of costs? Was it because of access? Was it fear? I mean, what were the reasons that they were not able to get to a dentist to treat these conditions? So that is absolutely something that is important. And many studies out there have looked at emergency department data and have done some analysis on that. Some studies have done inpatient hospitalization and done some analysis on that. And we also plan to do further analysis as well.
I wanted to ask you, Josefine, about so the conclusion of this particular study, because at the very beginning, you said that you wanted to use a kind of a systematic way to kind of help move the needle, I think is what you said, and it's about value-based approaches to improve the oral health. And so you take this information and you partner with the medical community, and then what?
Really, an upstream proactive approach is what is needed. Upstream meaning before it gets to this place. But as with any other public health measure, we have a current situation of people in need. And then we also have an opportunity to prevent people from getting to this place. So I'm using this information to advocate for those upstream approaches, whether that be increased funding or change in workforce practices. That's what this information can be used for. And that's how we at the Texas Health Institute would like to use this information to move the needle, to affect systems and system change. So what we mean by system change is not so much individually treating one patient at a time, which is valuable and it's important. And all of the medical and dental professionals that are doing that work, we value that. But we also see the need to change systems. We see the need to change and advance healthcare coverage, workforce policies, access to care, the way medical care is being funded, and the way it's being siloed as well. Those are all important things to take into consideration.
Now, you kind of serve an interesting kind of like your dental, but you also have kind of like this public health bigger approach or bigger view, high level overview. When you're looking at the diagnoses that are happening in the hospitals, do you feel like there is room to improve kind of like the overall diagnostic approach to dental disease or oral disease? Or do you feel like they're pretty much hammering it pretty good?
I feel like they're able to identify and diagnose with ease. The problem is that hospitals are not set up to effectively treat dental disease, especially in an emergency department setting. Sometimes hospitals, and they all are different, but in most cases, they employ an oral surgeon who can come in and provide some sort of dental treatment, but it's not by any means comprehensive. And just like any other chronic disease, if you're only treating the results of a disease and not the causative factors of a disease, it's just going to progress. And when we think about systems change, we think about how this affects us as a system, this is not only affecting a tooth, it's affecting our workforce. It's affecting our tax revenue because of lost work hours, because of children who cannot be educated to their highest potential. So when we look at the issue, to really look at it from a big picture perspective and look at really how it's affecting us in the big scheme of things, because we as dental professionals, we're all about oral health, but we really need to be able to explain these situations and explain these conditions in terms that are important to the population that we're speaking to, whether that be school officials, whether that be our politicians, whether that be our patients, and really speak to what they value. And that is not always going to be about healthy teeth, but we have the opportunity here to explain how a healthy mouth will impact and improve every aspect of our life and save lives.
This actually sounds so familiar. This is, I'm sorry, a complete digression, but it is very parallel to what you're saying right now. My first trip in Uganda, they were talking about malaria. You know, like we were having conversations with them at every aspect about sleeping under the mosquito net. Not just sleeping under a mosquito net to prevent malaria, but how much it would cost you to not work, how you couldn't go out and tend to your crops and feed your family. So it's not just one night without sleeping under a mosquito net. It is many months of recovery, and then the detriment to your family after that, even taking it a step further and teaching them how they could save their money. So it was like, it wasn't just don't get malaria. Malaria comes from mosquitoes, sleep under a mosquito net, you stay healthy. It was these like spokes on that wheel that we're talking about all these aspects, because honestly, sometimes it's just like, you know, throw until something sticks, and whatever resonates with that human being, maybe it's caring for their kids, maybe it is aesthetics, maybe it's, you know, saving money, or maybe they love their job or whatever it is, but just kind of throwing it until it sticks and finding whatever works for them that will make them see that it's not just keeping teeth healthy, it's about preventing disease.
Right. Really being able to identify the values of the individual or our audience is important. And you're right. The secondary effects that families experience from having a hospitalized family member are are enormous. We found that women were 16.5% more likely to be affected by this than men. And we know that women, for the most part, are the caregivers in their families. So then you have this additional emotional burden. You have the non-health effects, such as the disruption in childcare. And those things are very difficult to calculate.
How is the medical community responding to this data? Because I know us, like we in dentistry, we're going to have to find our way to disseminate this information. And these are kind of things that we already understood. How do you think the medical community is going to take this and also disseminate it? Do they even understand it enough or believe it enough to disseminate it?
I think the medical community recognizes that there is a need for comprehensive dental care outside of a hospital or an emergency department setting. And they are definitely on board with trying to move the needle to help their patients. We see a lot of advances in intercollaborative practice. We see a lot of medical providers being trained. For example, at AT Still University, they are training their osteopathic medicine students to do some minor things inside of the mouth to prevent some of these situations that begin in the emergency department, ending up in hospital setting.
Are you talking like procedures or just things like maybe putting fluoride varnish on or silver diamine?
I actually just saw an article recently that they were teaching the osteopathic medicine students on how to give injections inside of the mouth. We know that there are currently physicians that are applying fluoride varnish in their pediatric practices. So different things like this. We know that in some states, there was one state, and I forget which one it was, but now dentists will be able to administer vaccines in their dental practice. So we have to remember that it's the patients that is our number one and only priority, that they get the care that they need, whether it be through the dental office or through the medical professional. But certainly there's no excuse for 196 individuals in this one state. This is just one state. This is not the United States. This is only Texas that have lost their lives.
Anything else that we can break down in this study? This is so great.
Again, the important thing to remember here is that the best use of our monies we want to consider is that to treat someone in an inpatient setting, looking at the hospital charges, or would that money be better spent in preventive care? And really, to further build on this study, we would want to find out why folks are not able to access a dentist, or what is keeping them from receiving care at a dental office. So really learning the story about how they ended up in that inpatient setting, I think, is also important.
I honestly had never thought ER, like they go to the emergency department, that's a good resource to start gathering data to see how many people are having to go to the hospital for dental pain. I just never thought it would be inpatient. Like, this is kind of blowing my mind a little bit that there's this many people that had inpatient care for dental disease.
Right, Michelle, the number is very high. I mean, it was almost 48,000 individuals over that 10-year period that were admitted into the hospital for non-traumatic dental conditions. That doesn't account for the folks that went to the emergency department and were not admitted. That also does not account for the people who never made it to the hospital, or perhaps died of another cause and the dental condition that they may have had was never recorded either.
It seems like putting this type of project together is very time consuming, and there's a lot of people involved, a lot of moving parts. Maybe you can speak a little bit to that, and then what else do you have coming up?
First of all, we're very proud of the report. And the Texas Health Institute really invested a lot of time and effort into the report. We had funding support provided by the DentaQuest Partnership for Oral Health Advancement, which we could not have done this report without them. And the numerous man hours that went into this by our executive director, Ankit Singhavi, and my research analyst, Gaurav Patel, really our hard work paid off because it's a very good in-depth report. And what we hope is that this report will be able to move the needle to help advance oral health in the state of Texas and the residents of Texas, and really that other states can then model their research off of this report as well. And we would like to do further research on the data that we have to include some of the things that we talked about today as well.
So we have a lot of students and new grads that are listening, and I would really love for you to speak to like why doing these kind of data sets and running these reports matter to you and why they make you excited as a dental hygienist.
One of the reasons we thought it was so important to do this 10-year analysis was to really be able to tell the story for Texas over this 10-year period, to really be able to say, look, these are the lives that are being lost. These are the lives that we could help. These are the tax dollars that we could stretch. That's really one of the main reasons that we created this report, to help our policymakers, to help our community leaders, to help other public health researchers as well advance their work.
And if you had to give any advice to new grads or students that maybe only saw themselves doing clinical, maybe they were like, I'm graduating, going into private practice, and this maybe has stirred something in their soul. Do you have any thoughts or words of wisdom to get them excited and maybe continue? Maybe they work in private practice a little bit, but keep that passion alive for the public health sector?
Public health is such a wonderful place to be. The opportunities that we have to help our communities are enormous. We all have to start somewhere as well. Maybe the study that you begin as a student is not at this magnitude. Maybe it's a smaller study. In fact, I wrote a much smaller study before I participated in this study. It was only analyzing 1 year of data, and I only looked at rural residents. So baby steps, build on those, and absolutely public health for a dental provider, whether you're a hygienist, a dentist, a dental assistant, it is very fulfilling work.
Any final words about this study that you want our listeners to know about?
Well, we really appreciate you taking the time to listen to what we have to say about the study. A lot of times when we as researchers talk about our findings, we talk about the statistics. I always say statistics are stories with the tears wiped away. Let's bring those tears back. Let's talk about what is really affecting our populations. Let's talk about the stories behind each one of these individuals. It's difficult to talk about each one of the 47,000 individuals that ended up in the emergency or in as an inpatient, but we can definitely move the needle by looking at reports like this and then beginning to speak to others and begin the narrative in our communities about some of these findings.
Amazing. And if anyone has more questions or would love just to reach out to you, how can they do that?
So they can look us up. Texas Health Institute is our website. Look under the oral health program and you'll find my contact information. It's jwolfe@texashealthinstitute.org.
We appreciate you always coming on the podcast and being a listener. And I hope everyone takes this and actually shares it because it's really important information. And I know it's not just Texas, it's happening in all of our states.
Absolutely. Thanks for having me.
Of course.
Thank you. We hope you enjoyed this episode powered by Crest+Oral B. And be sure to check out the show notes and click the link to get your CE credits for this course. Also, you can check out dentalcare.com for more on-demand CE courses.
And to listen to more great episodes from us, you can go to ataleoftwohygienists.com. You are welcome to send us emails with feedbacks, questions, comments at ataleoftwohygienist@gmail.com. And you can always find us on any of the social media like Facebook and Instagram. And we welcome all direct messages and sharing of all the episodes.
Be sure to stay tuned for more bonus episodes powered each month by Crest+Oral B.
Anything else, Andrew?
I think that's it. Have a good week, everyone.
Bye, y'all.
Bye.